switched on? Is it plugged in? Oh, you have to plug it in one more. Does it work?
Okay. You might have to speak up because I'm not sure if you can hear me. Barry, can you hear me?
Yep, I can hear fine.
Okay. Where should I stand? Here is okay?
Just a little bit. Yeah, right there.
Okay. Okay, so let's start. Thank you so much everyone for coming here today to listen to my thesis project. With a lot of interest and pleasure, I'd like to introduce to you my topic, which is theory, disruptive innovation, and the practical application in real life in the North Umbria Trust. This is the agenda of the presentation. I'll start with the problem definition and wrap up with the conclusion, and in the middle I'll explain everything. Problem definition. The healthcare sector has been struggling for many years all over the world, but especially in the last few years, some factors have accentuated this problem even further. Most importantly, the financial crisis of 2008-2009, forcing a lot of European countries to take severe austerity measures, aging population, expensive technologies, and high expectations of the patients. All this combined has led to a huge unmet medical need. This has therefore made the European Council and the European Commission to invite all member states to take innovative steps towards healthcare reform instead of merely cutting budgets and reducing costs. Disruptive innovation is a theory that could offer a solution to one step forward toward this reform. It has been introduced and discussed since the early 80s. It's quite complicated, but I will try to simplify it as much as possible. I'll reference Christensen, which is a professor from Harvard who did extensive work in this field. In his words, a disruptive innovation is an innovation that sneaks in from below when dominant players are busy making their products more complex and more sophisticated. Disruptive innovation, on the other hand, offers something simpler, something more affordable, and therefore more accessible. I'll give you one example, which is the mainframe computers. This is an example from industry. Mainframe computer used to occupy a huge room and was very complex. Then it developed into desktop computers and then laptops, and now practically our mobile phones are our computers. Another example from products from the healthcare is the glucometer, which is a little instrument that measures the blood sugar in diabetic patients. And with this instrument, the patient can see their blood sugar at the comfort of their home instead of going to the hospital and seeing the doctor. But these are examples of products. And when the theory was first introduced, it only defined products. With time, it expanded to also involve business models. In business model, it is important to note that the theory doesn't introduce a new to the world product or something that didn't exist. On the other hand, it just redefines an already existing service or product just to make it delivered to the customers in a different way. An example from industry is Amazon. Amazon is selling the same product, but just in a different way than the normal conventional shops. I'll give examples from healthcare. The first one, as Christensen described, is disruption of healthcare institutes. He said that instead of having huge general hospitals that deliver everything under one roof, maybe it's useful to have focused care centers that specialize and focus on one or few diseases, and then they can become quite good quality and offer less expensive services. Another example is disruption of healthcare professions, and of this he gave an example of nurses. Nurses are quite qualified to handle a lot of diseases, and this can free up the highly specialized physicians, the consultants, to handle the more complex cases. When we talk about medical workforce, we have to keep in mind that under the roof of a hospital works many different professional groups. And many times they have completely different priorities and perceptions. A study done by Peter Degling in 2003, he did surveying of 5,000 people who work in hospitals, different professional groups, to see how they prioritize different things. This was the result. So on the x-axis you can see systemization and autonomy, On the y-axis, you can see how important the resources impacts medical decisions. As you can imagine, doctors, they really valued their autonomy quite high. They didn't want to stick to systemized processes, and they didn't think that the resources should have an impact on their medical decision making. Just on the other side of the spectrum was managers. So with this graph, you can see huge gap in how different professional groups perceive priorities. With this big gap, it's so difficult to take steps towards reform because not everyone is on the same page. And with managers sitting in the offices taking decisions and asking clinicians, by clinicians I mean mainly physicians, but also nurses and other professional groups to implement them, it's not practical, right? So this leads to my research question. My research question is broken into two parts. The first part, I wanted to see a care model that had underwent progressive step towards change and investigate that model and see if it actually fits in the definition of disruptive innovation that I just explained. The second part was to investigate the managerial approach and see a managerial approach that is clinical led, where clinicians have a lot of involvement, and then see if there is a potential causality between the managerial approach helping to adopt this kind of innovation. My methodology, the first part was literature review. So I did all the background research for the theory. I found some case studies, but now we don't have time to go into all details. The second and most important part was a single qualitative case study. For that, I traveled to the UK. I spent 2 months there, and I used multiple data sources, which is advised by Yin, who is a researcher in the qualitative case studies. So my main tool was expert interviews. I developed an interview that lasted 1 hour. It was composed out of 40 questions, 20 open-ended questions and 20 questions on a scale of 1 to 10. My interviewees ranged from the CEO, but I made sure to cover different professional groups. So this was my sample size, 27, 9 physicians, 8 managers, 5 allied health professionals, and by that I mean pharmacists, radiographers, physiotherapists, all support roles, and 5 nurses. Then I recorded all interviews, and I ended up with 27 hours of transcribing, like this, which took ages, like you can imagine. I clustered all the qualitative points together, and for all the questions that were on a scale, I used Excel sheet to calculate the averages for each of the professional groups and also for all the professional groups combined for each question. You will see all that in a little bit. Why did I choose this trust? By the way, trust means this is the term used in the UK to cover a certain geographic area and a certain population. Each trust might consist of many hospitals, but lie under the same managerial umbrella. So I chose this trust because, like many healthcare institutes, they are facing a lot of external pressures, especially austerity. They took a huge step towards change. And third, they have a clinically led managerial approach as explained by them. A little bit about the trust background. The trust is in the northeast of the UK. It covers 500,000 population. It is the trust covering the largest and most rural geographic area in the UK. And it was composed of 10 hospitals. 3 hospitals that offered emergency care, but also 7 community hospitals, all spread all over this huge geographic area of 2,500 square miles. The problem they were facing was that with this huge geographic area, the consultants, which are the highest qualified physicians, were quite thinned out when they were spread. They weren't on the hospital many hours because they were trying to cover all these sites. And according to evidence, they saw that the patients who came on weekends when consultants were not present, when they came with serious conditions, they had less chances to survive than the ones who came when consultants were present. So they wanted to address this problem. What they did is that they built a new hospital, North Umbria Specialist Emergency Care Hospital, NSIC. NSIC opened only 1 year ago, 1 year and a few months ago, in June 2015. The idea of NSIC was not just to build a new hospital. The idea was to centralize emergency care. So all emergency services were centralized from the 3 base sites, I will refer to them from now on, to NSIC. And the other 3 hospitals were downgraded to handle urgent care, but not life-threatening conditions. By that, they had the dedicated diagnostics in NSIC for the highly serious conditions, but also on the emergency care centers. So less serious patients don't have to wait all the time because there is a more serious accident or something like that. So they did a physical dislocation of acute from non-acute services, which is quite new because usually one hospital delivers all, right? And this is what was the result. NSIC has 24/7 accident and emergency consultants. It has 12 hours a day consultants in all emergencies, also on the weekend. On the other hand, the base sites, the nurses and the other professionals were upscaled to be able to handle cases. Consultants still go to the base sites, but they don't spend a lot of time there, and at night, nurses are qualified enough to handle all cases alone without referring to a consultant. I asked them why was the change adopted, and you would imagine with austerity, financial aspect would be a big reason, but actually it wasn't. The main reason was quality, according to all professional groups, and workforce, because they said, like I explained, amalgamating the consultants on one side was the whole idea of getting them to cover more hours. Financial aspects and targets ranked quite lower on this scale out of 10. I asked them about the key success factors in implementation, and everyone told me that it took a long time. It was more than 10 years in the planning. And one physician, I quote him, he said, "You have to remember that you don't go from zero to hero in a blink of an eye. It's a progressive leap." The second point was financial stability. The trust had its own commercial arm that made profit from even renting cars. But this money went directly to the healthcare services, and then they didn't have to feel this huge financial pressure, and they could actually focus on quality and what matters most for the patient. Third point was staff engagement, and they said that the physicians were involved even in the designing with the architecture of the hospital. So this is the hospital from inside, and they designed it to look as circles. So the nurse, when she sits in the middle, she can see all rooms, instead of having a long corridor where the nurse doesn't see the patient who's at the end of the corridor. The last point was public and politician engagement. They had public consultation, and they involved members of parliament and all this. I asked them about the obstacles. I selected 5 obstacles from literature that were defined as the highest or biggest obstacle in disruptive innovation, and every time I got consistently low rank. Nothing was above 5. Funding was ranked as the highest, as you can imagine, with 4.9, but everything else was quite negligible. Successes, I asked them about successes, and they scaled all 5 aspects I asked about as quite successful. I then took what they told me and had a meeting with the head of the data department. I tried to be like an investigator. So I wanted to really validate what they told me and see if it's true. And actually it was true, because the trust was performing quite well on a national level in terms of patient satisfaction. It was rated the 10th out of 150 in terms of staff satisfaction, in terms of financial gains and everything else. Second part is the managerial approach. So I had a quick look, and I asked them about how the managerial structure of the trust was going, and they told me that the trust was broken into 5 business units. For each business unit, they had business unit director who is a physician and deputy director who is a manager. They have equal votes, they work side by side, and they communicate all the time. For each business unit, it had its own autonomy, it had its own budget, and it can make decisions. If we look, these are the same graphs that I showed you earlier about the reasons and the obstacles. I broke them down into to look at the different professional groups, how they rated each of them. And it's interesting to see that on a scale of 1 to 10, the biggest difference was 4 points on the scale, which was usually between nurses and managers. But between physicians and managers, it was always 1 or 2 points. It was never more than that, which is a proof that having physician and manager work side by side really pays off, because they have the exact same perception of what is important and what is not. I then asked them 3 further questions about how do you feel involved in managerial decision making, do you feel that you are encouraged to innovate, and do you feel that the values of the trust are well communicated. And all professional groups again rated all 3 aspects high and quite similar, more or less. Next part was, if you remember Peter Dedling graph with the X and Y axis where all professional groups were scattered all over, I asked 4 questions to try and see if they had similar opinions. And also you can see that the opinions are quite similar, so everything is quite similar. And the first time that I received 10s on the question was the importance of multidisciplinary teams and working together. An interesting fact is that autonomy was rated quite low by physicians but quite high by nurses, which shows that at least physicians moved from their earlier position where they wanted a lot of autonomy. The last thing was an explicit question of how strongly do you think the correlation between the clinical-led managerial approach and the adoption of innovations, if the presence of clinicians on the board actually helped in adopt these disruptive innovations, and the answers were 9, 8, 8, and 9 out of 10. So, by that we wrap up the conclusion. Is it a disruptive innovation? According to Christensen, it should be more affordable, which was shown from the graph. It should be simpler, which was shown, and it should be more accessible. And this way, it is more accessible because with nurses running the urgent care centers, patients can go anytime and they don't have to wait so long. The second question was clinical-led management. Did it help in adoption of disruptive innovations? And the answer again is yes, especially after you saw my last slide with the explicit question and their answers. I finished with a quote from one of the nurses, and she said the success factor we had was the strategic clinical leadership, managers and clinicians working together and being an organization that has a can-do attitude, prepared to consider the unthinkable, and seriously wanting just to improve things for our patients, population, and staff. Ladies and gentlemen, this is the journey I just explained over the last 15 minutes, and it stays on one of the biggest walls of the hospital to communicate with the public of why was the change adopted, what was exactly done, and I thought it would be beautiful just to end with it, and thank you so much.
Thank you very much, Nancy, for this both detailed and clear presentation. I would like to ask Barry again to start the discussion.